Well, good morning, everybody, and welcome to Medical Grand Rounds, back today after yesterday's Martin Luther King Jr. Day. Just a few logistics to get started with. A reminder that next week's speaker will be Dr. Ben Pedroca, who will be giving the talk Update in Hospital Medicine from 2022, a year in review. And that talk will actually be live here in Southern Auditorium at Providence St. Vincent on Tuesday, and live at Providence Portland Auditorium on Wednesday. Grand Rounds is now a collaboration between St. Vincent and Providence Portland, and we will continue to keep you updated about where you can see the event live. You can always be with us here on Teams Live, and you can also watch a recording of the session. You can earn CME credit for participating in any of those formats. There's always a follow-up email after our talk, and you can find the link to the recording at the same link as the invite for Grand Rounds. I'll be monitoring the Q&A throughout today's session, so please go ahead and post any comments or any questions that you have, and I'll mostly hold those till the end as time permits. And now to introduce today's speaker, we are joined by Dr. Abby Fry, Clinical Pharmacy Specialist with the Providence Medical Group. In her current role, Dr. Fry provides collaborative management for patients with chronic illness, including diabetes, hypertension, and osteoporosis, among others. She serves as a drug information resource for other providers and is also heavily involved with the education of internal medicine residents, pharmacy residents, and students. Dr. Fry earned her degree in chemistry from Central College in Pella, Iowa, before coming out west to attend pharmacy school at the University of Washington. She then completed her 2 years of residency with Providence Health and Services, including a PGY2 year in primary care with Providence Medical Group. In addition to providing direct patient care and precepting, Dr. Fry enjoys writing and editing the Clinical Pharmacy Department's Drug Information Newsletter and lecturing at the Oregon State University College of Pharmacy. I feel so fortunate to work beside Dr. Fry on a daily basis, and we're delighted to have her come teach us again today. Thanks.
Thank you, Laura. Thanks for that nice introduction. Excited to be back here to give Grand Rounds. And thanks for those of you joining us in person and online. So as Laura mentioned, one of my roles as a clinical pharmacy specialist with the Providence Medical Group is writing and editing our department's newsletter, RX Hot Topics. RX Hot Topics, we publish every 6 to 8 weeks and seek to review relevant clinical guidelines, guideline updates, FDA updates, new drug approvals, new warnings or alerts, and also provide clinical and prescribing pearls. I will admit we've struggled sometimes lately with our distribution list, so if you don't know what I'm talking about and wish you were getting RX Hot Topics, please send me an email afterwards. We'll make sure we get you on the list. The objectives of our newsletter, as well as my Grand Rounds today, are to evaluate recent studies that provide pertinent information about medications, to identify emerging safety concerns with commonly prescribed drugs, and to discuss new evidence that clarifies the role of established therapies. In order to choose the topics for today's session, I looked back over the last year's worth of our Hot Topics newsletters and picked out 5 topics that I thought were particularly interesting and broadly relevant. I'm going to start with the TIME trial, which looked at the cardiovascular outcomes associated with taking antihypertensives either in the morning or the evening. Then we'll talk about the CLIC study, which looked at chlorthalidone for hypertension and advanced CKD. We'll take a brief look at the updated PrEP guidelines, which introduced cabotegravir, an injectable option for HIV pre-exposure prophylaxis. Then we'll look at the FIDELITY Analysis, which evaluated finerenone in patients with type 2 diabetes and CKD. And finally, the SURPASS-2 trial, which evaluated tirzepatide versus subcutaneous semaglutide in patients with type 2 diabetes. And in between topics, I'll just treat you to some unrelated photos from a recent trip to the Grand Canyon. So starting with the TIME trial, again, this sought to answer this question: does the timing of antihypertensive therapy matter? So what we know is that nocturnal hypertension is a significant risk factor for cardiovascular disease. There's been multiple trials that have shown folks with higher blood pressure overnight or a non-dipping pattern have an increased risk of cardiovascular events. Two trials, the MAPEC trial published in 2010, and then the HYGEIA chronotherapy trial published in 2020, showed substantial reductions in cardiovascular outcomes when patients were randomized to take their antihypertensive medications at bedtime. However, there was some controversy regarding the results from these trials. Both of these trials were conducted by the same research group in Spain, and the plausibility of the effect sizes was questioned by some. They saw an over 50% reduction in cardiovascular outcomes with pretty low number needed to treat of 19, and some of those some experts questioned the plausibility of these results. And as a result, several other groups embarked on studies seeking to either confirm or refute these findings. The first of these was published in The Lancet in 2022. This was the TIME study. In the TIME study, they recruited adults with hypertension in the United Kingdom who were taking at least one blood pressure medication. Folks taking blood pressure medications that required twice daily administration, or folks that worked the night shift were excluded. And in total, over 21,000 adults with hypertension were randomly assigned to take their usual medications either in the morning between 6 and 10 a.m. or in the evening between 8 and midnight. The primary outcome was cardiovascular death or hospitalization for non-fatal MI or non-fatal stroke. And the median follow-up was 5.2 years. Primary endpoint events occurred in 3.7% of patients assigned to the morning group and just 3.4% of patients assigned to the evening group with a hazard ratio of 0.95. There was also no difference in all-cause mortality or other secondary outcomes. So in summary, the findings from this trial show that timing probably doesn't improve outcomes for the broader population. This study did not look at specifically patients who are identified to have nocturnal hypertension. This was just a broad general population of folks with hypertension. And in that broad population, taking medication in the evening was not harmful, but it also provided no additional benefit compared to morning dosing. However, evening dosing or kind of mandating or recommending evening dosing might affect adherence. Other previous studies have found that evening dosing is generally associated with worse medication adherence. So my takeaway is that we should focus on what matters. We should focus on choosing good blood pressure lowering medications, long-acting medications that require just once daily administration when possible, using combo pills when possible to reduce pill burden. And then trying to support our patients with good adherence. And for some patients, that might mean taking their blood pressure medications at night, if that's the time that they can be most consistent with them. But for others who morning dosing works better, I think that would be just fine. And then focusing on treating to our treatment goals that have been shown to improve cardiovascular outcomes. There are a couple other related trials. The BEDMED trial and the BEDMED-FRAIL trial are two studies being conducted in Canada that are similar to this UK trial, and the results are still pending for those, but I think that will really solidify this finding depending on those results. Okay. Next up, let's talk about the CLICK trial. The CLICK trial looked at chlorthalidone for hypertension and advanced CKD. So what we know is that hypertension is often poorly controlled, especially in people with advanced CKD. And due to their comorbid advanced CKD, we're often limited in what drugs we can use. We also know that chlorthalidone has demonstrated benefits not just for blood pressure lowering, but also target organ damage in the general population in studies from like ALL-HAT, SHEP, and SPRINT. However, clinical opinion and guidelines have previously recommended against the use of thiazides when eGFR is less than 30 due to concerns about inefficacy. And I know that I certainly have made the recommendation to switch to a loop diuretic from a thiazide when eGFR is very low in order to get more efficacy. In an attempt to refute the dogma that thiazides lose effectiveness at this low eGFR, investigators at 3 academic hospitals in Indiana conducted the CLICK study. They enrolled 160 adults with stage 4 CKD, defined as eGFR of 15 to 29, who had uncontrolled hypertension and were already on at least one blood pressure lowering medication. They randomly assigned these participants to either receive chlorthalidone or matching placebo for 12 weeks. Chlorthalidone was started at a dose of 12.5 milligrams a day, and then the dose was doubled every 4 weeks to a max of 50 milligrams a day if home systolic blood pressure remained over 135/85. And the primary outcome in this case was a change in 24-hour ambulatory systolic blood pressure after 12 weeks. Looking at the participants in this trial, the mean age was 66 years. The majority were male. One of the hospitals was a VA hospital, which might have led to this. There was good representation of both white and Black patients, with 40% of the population being Black. And then the majority had diabetes. The mean eGFR was 23, and the median urinary albumin-creatinine ratio was 862. Participants were on an average of 3.4 antihypertensives at baseline, which I think also shows the difficulty in controlling hypertension in this population. 60% were on an ACE or an ARB, 60% were on a loop diuretic, nearly all, 75% were on a beta blocker, and 65% were on a calcium channel blocker. And at 12 weeks, chlorthalidone was associated with a really significant decrease in systolic blood pressure, with an 11-point decrease. It also showed a significant reduction in the urinary albumin-creatinine ratio of 50%. As expected, kind of all of the adverse effects we know chlorthalidone is associated with did occur more in the chlorthalidone group. So there was more hypokalemia, hypomagnesemia, hyponatremia, hyperglycemia, reversible increases in serum creatinine, and dizziness. Taking a closer look at these results, as I mentioned, the chlorthalidone could be increased to a max dose of 50, but you can see that the mean dose at the end of the 12 weeks was 23.1. So that chlorthalidone was generally not increased to that max dose. And you can see that at 4 weeks, you really saw the bulk of the blood pressure lowering, with 9-point systolic reduction at that starting dose of 12.5. And I think this suggests that low dose is effective, especially here in these patients with advanced CKD, and might be the safest dose in order to prevent the adverse effects or to minimize the risk of the adverse effects that we are associated with chlorthalidone. So in summary, chlorthalidone is an effective antihypertensive even in patients with advanced CKD. However, it's certainly not a prescribe and forget situation. Careful monitoring is required in order to ensure safe use in this population. We need to be monitoring serum creatinine, potassium, magnesium, and sodium, and repleting or adjusting therapy as needed. Although the reduction in blood pressure and the reduction in the urinary albumin-creatinine ratio were impressive, the study was too small and too short to evaluate those hard clinical outcomes that we know are so important. Okay, moving on to the updated PrEP guidelines. The CDC released updated PrEP guidelines at the end of 2021, around the same time that cabotegravir was approved for use in PrEP. 35,000 people in the United States received a new HIV diagnosis in 2019. HIV continues to disproportionately affect people of color, with 74% of new diagnoses in people who were not white. In particular, 42% of all new diagnoses were in Black or African American individuals, with 27% of new diagnoses in Hispanic and Latino individuals. In order to decrease the rate of HIV transmission, it is really critical to educate patients on the availability of PrEP, or pre-exposure prophylaxis. Historically, there have been 2 oral daily options, emtricitabine and tenofovir, or Truvada in its generics, which was approved for PrEP over 10 years ago in 2012. And then more recently, the emtricitabine tenofovir alafenamide preparation, or TAF, which is sold under the brand name Descovy, which was approved for PrEP in 2019. Cabotegravir, or cabotegravir long-acting is a long-acting integrase strand inhibitor, which is administered via gluteal IM injection every 2 months. You can use an oral 28-day lead-in with oral cabotegravir. This is really recommended for individuals who are worried about side effects, but severe adverse effects are extremely rare, as we'll look at here in a minute. So the oral lead-in is not mandated or required. You can just start with the injectable option. The efficacy of cabotegravir for PrEP was demonstrated in 2 trials, HPTN 83 and HPTN 84. In HPTN 83, 4,500 cisgender men and transgender women were randomized to receive the long-acting cabotegravir or the emtricitabine tenofovir preparation, or Truvada. There were 52% participants who acquired HIV after enrollment, 13 in the cabotegravir arm and 39 in the Truvada arm, for a 66% lower risk of HIV in the cabotegravir arm. Inadequate adherence to the daily oral option seemed to drive this finding. We know from previous studies that when taken as prescribed, emtricitabine tenofovir is 99% effective for PrEP. However, in this study, when they looked at adherence rates were low in the folks that acquired HIV in the oral daily arm. In HPTN 84, over 3,000 individuals who were assigned female sex at birth in sub-Saharan Africa were randomized to the long-acting injectable cabotegravir or the emtricitabine tenofovir. And again, in this case, we saw superiority with the long-acting cabotegravir. There were 40 participants who acquired HIV after enrollment, 4 in the cabotegravir arm and 36 in the emtricitabine tenofovir arm, meaning that HIV risk was 88% lower in the cabotegravir arm. And again, poor adherence to the daily oral option seemed to drive this finding. They found poor or non-adherence in 35 of their 36 cases in which HIV was acquired in the tenofovir arm. In both of these trials, as I said, severe adverse effects were very rare. The most common was injection site reactions were relatively common, 81% in the first trial, 38% in the second trial. However, these were rarely severe and rarely resulted in treatment discontinuation. So looking at our PrEP options and the pros and cons of them. So our traditional kind of first approved in 2012 option, which is Truvada in its generics, one of the big pros is the generics are available, which substantially reduces the cost of this option. The emtricitabine tenofovir option has also been studied for an on-demand PrEP or 211 in select patients, specifically in men who have sex with men. However, it is contraindicated if creatinine clearance is less than 60, and as a result, renal monitoring is required. And again, as we pointed out in the previous studies, daily adherence is required. It's highly effective if taken daily, but as we can see, less effective when poor or non-adherence is a factor. More recently, the emtricitabine TAF option, or Descovy, was approved for PrEP in 2019. The advantage or difference between the two is not efficacy. The Descovy option was shown to be non-inferior as compared to the Truvada option. The difference is that the tenofovir alafenamide option is less likely to cause kidney or bone problems in patients, so it might be a good option for folks with reduced renal clearance or have a history of osteoporosis. However, it has not been as well studied. Specifically, it has not been studied in those assigned female sex at birth, so it should not be used in those populations. Renal monitoring is still required because it's contraindicated if creatinine clearance is less than 30. And it's also been shown to have some negative effects on lipids, so annual lipid monitoring is also required. It once again requires daily adherence, which can be a barrier, and it is not generically available, so it is very expensive. The monthly cost of around $2,000 cash price. And then finally, our most recent option, cabotegravir, the injectable long-acting cabotegravir specifically. This obviously does not require daily adherence. Again, after a kind of run-in phase where you do it once for the first 2 months, then it's every 2 months, so just 6 injections per year ongoing. Although it does not require daily adherence, patients do need to be adherent to those appointments. It's a medication that's administered at a clinic visit. There's no renal or lipid monitoring required, which is a big plus. Injection site reactions are common, but usually not severe. There's been some concern about this class of medications causing weight gain, but significant weight gain was not seen in the trials that I reviewed previously. However, the cost is high, with an annual cost of over $20,000. So in summary, the guidelines call for us to inform all sexually active adults and adolescents about PrEP. We should offer PrEP to any patient at substantial risk for HIV or any patient who requests it, even if we cannot identify a specific risk factor for those patients. So basically, we should not withhold PrEP from anybody who is interested in it. Before prescribing PrEP, it's important to confirm that the individual does not have HIV and should also screen for chlamydia, gonorrhea, and syphilis if they are sexually active. And then if considering oral PrEP, it's important and required to assess their renal function before initiation. The cabotegravir or long-acting injections can and should be considered for folks who have had issue with adherence to oral daily PrEP, or those who prefer to get an injection every 2 months instead of taking oral daily PrEP. And finally, those who have a creatinine clearance less than 30, which prevents the use of oral PrEP options. Here at Providence, our pharmacotherapy clinics can help us both with the administration and the procurement of cabotegravir long-acting for PrEP. Okay. Next up is the FIDELITY Analysis. This analysis evaluated finerenone in patients with type 2 diabetes and CKD. Finerenone is a novel, selective, non-steroidal mineralocorticoid receptor antagonist, which is approved for use in adults with CKD associated with type 2 diabetes. Non-steroidal MRAs are more selective for the mineralocorticoid receptor, and they have a lower risk of hyperkalemia as compared to the steroidal options, such as spironolactone. Finerenone was evaluated in 2 kind of parallel studies, the Fidelio CKD and the Figaro DKD trial. These trials looked at adults with type 2 diabetes and CKD who were receiving a maximum tolerated dose of a RAS inhibitor and had a serum creatinine of 4.8 or less, and these patients were randomized to finerenone 10 to 20 milligrams a day versus placebo. The Fidelity Analysis pooled these 2 studies in order to get a broader population of folks with diabetic kidney disease. In total, there were 13,000 patients with a median age of 65 years, majority male with 70% male. The mean eGFR was 57, with a median urinary albumin creatinine ratio of over 500. Nearly half of these patients had a history of ASCVD. The mean A1C was 7.7, with a mean systolic blood pressure of 136, so fairly well-controlled diabetes and blood pressure. And patients with HFrEF were specifically excluded. Based on inclusion criteria and standard of care, nearly everyone was on a RAS inhibitor. About 3/4 were on a statin. At the time these studies were started, SGLT2 inhibitors were not standard of care for treatment of CKD, so a pretty small percentage, just 6.7% were on an SGLT2 inhibitor at baseline. And then that increased as the studies went on, as we got more evidence regarding the SGLT2 inhibitors. So a total of 15% of patients took an SGLT2 inhibitor at some point during the trial. They looked at 2 primary outcomes, a composite cardiovascular outcome, which included cardiovascular death, non-fatal MI, and non-fatal stroke, as well as a composite kidney outcome, which was made up of kidney failure, renal death, or a sustained decline in eGFR of over 57%. And as you can see here, both of those were found to be significant with the finerenone group. So there was a reduction in that composite cardiovascular outcome with a number needed to treat of 59, and also a reduction in the composite kidney outcome with a number needed to treat of 63. And this was over a median follow-up of 3 years. There was also a reduction in heart failure hospitalizations and of end-stage kidney disease alone. Hyperkalemia was more common, only rarely required permanent treatment discontinuation. Just 1.7% of patients had to discontinue treatment due to hyperkalemia, and rarely required hospitalization with less than 1%. In most cases, hyperkalemia that was observed was managed by just stopping the drug briefly and then using dietary reduction, sometimes diuretics, in order to manage. A subgroup analysis that was published in Diabetes Care just last year found that finerenone provided cardiorenal benefit regardless of SGLT2 use. So in folks that were on an SGLT2 inhibitor, the finerenone seemed to be at least as beneficial and perhaps additive in terms of the cardiovascular risk reduction. So looking at place in therapy, I'll turn to the ADA standards of care that were just recently published. The ADA recommends that for people with type 2 diabetes and CKD with albuminuria treated with a maximum tolerated dose of an ACE inhibitor or ARB, the addition of finerenone is recommended to improve cardiovascular outcomes and reduce the risk of CKD progression. The level of evidence A. And then looking at the KDIGO 2022 guidelines, they place SGLT2 inhibitors and RAS inhibitors as first-line drug therapy. They mention that the reason that SGLT2 inhibitors garner first-line drug therapy is due to kind of more significant and broader evidence regarding this class of drugs. And then if folks have persistent albuminuria and normal potassium, so again, that's potassium of 4.8 or less, after treatment with maximum tolerated RAS inhibitor and after treatment with SGLT2 inhibitor, then finerenone should be considered in order to reduce that risk. So in summary, we should be considering finerenone for persistent albuminuria despite maximal tolerated RAS blockade and plus or minus SGLT2 inhibitor use. Finerenone might be added to just RAS inhibitor if folks are have tried and failed an SGLT2 inhibitor, can't tolerate it, or are inappropriate for it. This is another drug that we can't just prescribe and forget. In order to have that acceptable safety profile that we saw in the Figaro and Fidelio trials, we need to make sure we're not starting this in folks with elevated potassium. So the trials use that 4.8 or greater. And then in the trials, potassium was checked 1 month after initiation and then every 4 months after that, which I think really allowed for them to use it safely and see that really low rate of severe hyperkalemia. So this is what I would certainly recommend in practice. You don't have to expect or worry about a significant blood pressure reduction. Unlike our steroidal MRAs like spironolactone, which are first-line therapy for resistant hypertension and can be associated with really significant blood pressure reduction, finerenone only modestly reduced blood pressure with an average of 3 points systolic. Cost and coverage may certainly be a barrier, and I think is why we're seeing very little use of finerenone in practice. This is yet another expensive drug to add to patients. The cash price is over $600 a month, and prior authorization will likely be required. The prior auths that I've seen for it require the patient to be on maximally tolerated RAS blockade and an SGLT2 inhibitor before finerenone will be covered. That's not always the PA criteria, of course, but I think prior authorization is likely. And then I think we're still waiting for some additional evidence. It's unknown if the beneficial effects associated with SGLT2 inhibitor and finerenone are additive due to differences in mechanism of action. I think that's plausible, but we don't have that evidence yet. And then we also don't have evidence regarding the use of finerenone in patients with non-diabetic CKD. Okay. Turning to our last topic, the SURPASS-2 trial. This looked at tirzepatide versus subcutaneous semaglutide in patients with type 2 diabetes. So we all know that GLP-1 receptor agonists are an effective treatment for type 2 diabetes, and some have been associated with cardiovascular disease benefit. And this is why our treatment guidelines for type 2 diabetes call for the use of GLP-1 agonists with that cardiovascular disease benefit in individuals regardless of A1C, if they have a history of cardiovascular disease or at very high risk of cardiovascular disease, and also recommend them for use in folks who preferentially over insulin and patients who need to advance to injectable therapy for additional A1C lowering. Tirzepatide is a novel dual glucose-dependent insulinotropic polypeptide, or GIP, and GLP-1 receptor agonists. And the idea is that the GLP-1 and GIP will be synergistic and provide additional A1C lowering and additional weight loss. If you attended last week's excellent grand rounds, you heard about tirzepatide a little bit because it is currently being considered by the FDA for treatment of obesity, but currently it is approved by the FDA for the treatment of type 2 diabetes. In the SURPASS-2 study, they evaluated tirzepatide versus our currently best-in-class GLP-1 agonist, which is semaglutide. Nearly 2,000 adults with type 2 diabetes who had inadequate control, so A1C of 7 or greater, on metformin, and at least metformin of 1,500 milligrams a day, were randomized. The mean age of these patients was 57 years. About half were female. Majority were white, so an underrepresentation here of people of color. The mean A1C was 8.3%, and the mean BMI is 34. So pretty kind of classic population of folks with type 2 diabetes, certainly similar to a lot of patients I see. These individuals were randomized to one of 3 doses of tirzepatide. So individuals are started at a dose of 2.5 and then titrated up to 5, 10, or 15 milligrams. And then the fourth arm was semaglutide, started at the starting dose and then titrated up to, at the time of this study, the max dose of 1 milligram a week. I will mention that we now have evidence to support the use of semaglutide up to 2 milligrams a week, but at the time of this study, this was the maximum dose. This was a 40-week trial. The primary outcome was change in A1C at the end of these 40 weeks, and the secondary outcome was change in body weight at the end of 40 weeks. So looking at the results, and the blue bars are tirzepatide at doses of 5, 10, and 15 milligrams, with the green bar being semaglutide. And you can see a dose response of A1C lowering in the tirzepatide arms, with the highest A1C lowering of 2.3% with tirzepatide 15 milligrams. The semaglutide 1 milligram was associated with an A1C lowering of 1.86, which is similar to what we've seen in practice in other clinical trials. All of the doses of tirzepatide were non-inferior and superior to semaglutide with regards to A1C lowering. However, I think, question the clinical significance of a 1.86 versus 2.A1C lowering. So I think in general, I would consider kind of similar A1C lowering, maybe a little bit better. In terms of change in body weight, you can also see a dose response. So the highest reduction in body weight was with the highest dose of tirzepatide, 15 milligrams. That was associated with an 11 kilo weight loss, compared to about a 6 kilo weight loss with semaglutide 1 milligram. And certainly that is a clinically significant difference in weight loss. But again, this is the semaglutide 1 milligram strength. We now have approval and evidence for use of up to 2 milligrams, and I think weight loss there would be a little bit more similar, but it does seem like the tirzepatide has an edge with regards to weight loss in these patients with type 2 diabetes. In terms of adverse effects, the most common adverse events were gastrointestinal related, which is not surprising given the mechanism. We're very familiar with these side effects related to GLP-1 agonists. The most common was nausea. These two seem to be dose related. So the highest dose of tirzepatide had the highest rates of nausea, up to 22%. So fairly common. Vomiting in up to 10% of patients, and diarrhea in up to 16% of patients. In the trial and in practice, the GI-related adverse events related with these agents, tirzepatide and our other GLP-1s, are primarily mild to moderate, primarily transient, with initiation or dose titration, which then improve with continued use. But I certainly know from my practice that they can be severe and dose limiting for some patients. And so it is something that requires counseling and certainly monitoring to ensure safe use. Other adverse effects were rare, but we can see things like acute kidney injury if the patient is vomiting and getting dehydrated. So a lot of the other adverse effects that we sometimes can see are kind of relate back to the GI related events. So in summary, regarding tirzepatide versus semaglutide, similar A1C lowering. Technically, by statistics, it was more A1C lowering with tirzepatide, but I think clinically I consider them somewhat similar, but certainly seemingly more weight loss with tirzepatide as compared to the best-in-class semaglutide. Same low risk of hypoglycemia. However, when these drugs, tirzepatide or any of our other GLP-1s, are added to a patient with type 2 diabetes who's already on a medication that can cause hypoglycemia, such as insulin, such as a sulfonylurea, that background therapy may need to be adjusted to prevent hypoglycemia. So on their own, very low risk, but when added to other background therapy, you can see some hypoglycemia if you don't adjust those medications. Tirzepatide has the same contraindications and precautions as the GLP-1s that we're familiar with, so they should not be used in anybody with a personal or family history of medullary thyroid cancer or multiple endocrine neoplasia syndrome type 2. Cautious use is recommended in folks with a history of pancreatitis, gallbladder disease, or diabetic retinopathy as well. An interesting kind of difference in the tirzepatide that I've recently seen is that its product insert and labeling indicates that it can reduce the absorption and therefore efficacy of oral birth control due to its reduction in gastric transit time. And so that would be something that we should be considering in folks who are using contraception to prevent pregnancy. They have the same high cost. I should say tirzepatide has the same high cost as the GLP-1s. These are very expensive medications, over $1,000 or around $1,000 a month cash price, and prior authorization will likely be required. And I think one of the biggest things that is kind of preventing or should hold us off on using tirzepatide frequently in practice is the lack of cardiovascular outcomes data. So 3 of our GLP-1 agonists that we've had, subcutaneous semaglutide, liraglutide, and dulaglutide, have all shown reduction in cardiovascular disease. We don't have that evidence yet with tirzepatide. Its cardiovascular outcomes trial is in progress. It's being compared to an active comparator, dulaglutide, but those results are expected next year. So that brings me to the conclusion of today's topics. We looked at the TIME trial, looking at cardiovascular outcomes associated with taking antihypertensives in the morning versus the evening. The CLICK trial, which looked at chlorthalidone and for hypertension and advanced CKD and showed great benefit in terms of blood pressure lowering. Looked at the new PrEP guidelines, which include cabotegravir and a long-acting injectable option that can be considered, especially for individuals who struggle with adherence to the oral daily options or cannot use the oral daily options due to renal function. The FIDELITY Analysis, which looked at the efficacy and outcomes of finerenone in patients with type 2 diabetes and chronic kidney disease. And then finally, the SURPASS-2 trial looking at tirzepatide. So with that, I left plenty of time for questions today, which is great. So hopefully there's lots of them. I thank you for coming, and hopefully there's lots of good questions.
Thank you so much, Dr. Fry, and you are quite wise because there are several questions that maybe we can rattle through a few from our online audience first, and then I'll gather from here in the room. Going back to your first topic, the CLICK trial with chlorthalidone, a question emerged. Would ARB prescribing twice daily likely be better dosing? Any comments on ARBs twice daily?
Specifically in CKD, I think depending on the ARB, I preferentially, when I get the choice, prefer to choose a long-acting second-generation ARB, such as olmesartan and irbesartan, which I think, based on their half-life and duration, can get good efficacy with once-a-day dosing. Losartan are kind of our first ARB, first to go to generic, so as a result, often used, is shorter acting, and I think there would be utility to dosing it twice a day or changing it to a longer acting product.
Great, many thanks. And now regarding the finerenone, can you comment on any idea of time to benefit with those with a life expectancy, for example, less than 3 years, likely benefit?
Great question. And not one I don't know if I can answer intelligently off the top of my head. I think based on our available evidence that in that trial being 3 years in length, I think it would be hard to say that we're going to definitely see benefit earlier than that. Hopefully we can get more information on that, because I think that's certainly relevant in folks that have more advanced CKD, and lifespan might be shorter.
Great, thank you. And I'll take one last online question, slightly broader topic. Any comments that you would have in general regarding the off-label use of metformin, and particularly benefits or potential dangers?
Oh, the off-label use of metformin for...
Yeah, unclear from our question. It sounds as though it's weight loss, longevity, seem to be some of the indications.
Prediabetes. I'd say, I mean, certainly there's evidence, and I think pretty good evidence of use for metformin for prediabetes. And I think one of the things I like about metformin is it's long, we have lots of experience with it. I think I feel very good about its safety profile. The most common thing we're going to see, assuming it's well tolerated long-term, is potential for B12 deficiency, which is easily monitored for and treated if need be. So for prediabetes, yes, I don't think there's a lot of evidence regarding its use for pure weight loss, unless there are comorbid conditions such as prediabetes or PCOS involved. I don't know, you're talking to a proponent of metformin. I spend a lot of my time convincing and encouraging patients to stay on their metformin when we're treating their diabetes. So I don't have a lot of negative things, but I think I also would tend to stay with the evidence, and unless there is a comorbid condition where we have benefit, I'm not sure we'd be gaining much.
Thank you, Dr. Fry. Just a couple of questions on a couple of the topics.
Great.
The first one I was going to ask about is in PrEP and the cabotegravir. So it sounded like the long-acting sub-Q formulations, or IM, ended up having some people still get HIV. Did they comment on the subgroup that was adherent to oral being superior to the IM at all? Do you know?
They did not. They did not. I did not see that kind of post hoc analysis of looking at kind of, they were assessing adherence and like levels of the tenofovir, so that might be available. I did not see that. But as you mentioned, there were a few cases in each group or in each trial of kind of breakthrough infections with the cabotegravir arm, whereas in previous trials with emtricitabine tenofovir, as I said, is 99% effective when adherence was high. So I think you could probably argue that maybe in those kind of perfect conditions that the oral daily option is very, very effective. If people can take a once daily medication, we know that. I think the utility is really for folks who can't, because then we have clearly seen that it's ineffective when they're taking less than 2-3 doses a week.
Thank you.
Yeah.
And then the other one was going to the time trial. In my past few years, I have definitely been pushing people to do nighttime dosing. And I guess, did they make any discussion or comment on 5 years being enough time to see any difference?
Yeah, great question. I will say same. First of all, I've wrote a previous Hot Topics about the Hygieia chronotherapy trial and with the take home of let's tell our patients to take their medications at night, because that all seemed like a pretty low risk intervention, and maybe it reduced the risk of cardiovascular disease. They did not comment on kind of that 5-year duration. I would have to remind myself kind of the duration of the follow-up for the previous trials that showed those substantial reductions. I think comparing it to other cardiovascular outcomes trials, I think 5 years is kind of in the ballpark of where we've seen other drugs, kind of other interventions have a benefit. And then again, like I mentioned, what question that study does not answer is when folks have nocturnal hypertension. For example, if we identify that they're non-dipper or have nocturnal hypertension with a 24-hour blood pressure monitor, is there a benefit of adjusting their therapy to change that pattern? We don't have evidence to say there's a benefit in that case, but this also didn't answer that question. And I think kind of plausibility that seems still reasonable, but kind of in that general population, if we don't have any evidence that they have nocturnal hypertension, we're just trying to treat hypertension, there doesn't seem to be a clear benefit of taking it at night.
Wondering about the indications for PrEP therapy in the non-sexually active population.
Yes. PrEP is recommended and should be offered to anybody who's using injecting drugs that are not prescribed to them. That it's indicated for, that would be considered a substantial risk for HIV. If you're injecting drugs that aren't prescribed, you should be offered PrEP.
Great, thank you, Dr. Fry. Another question here in the room.
Abby, this might be off topic and a whole lecture that you haven't prepared for, but maybe I was reading about the Inflation Reduction Act. Over the next few years, it's going to reduce insulin cost, cap insulin costs. It's going to make some immunizations free that currently aren't, but it's also going to cap out-of-pocket costs for Medicare patients. And I wonder if it's obvious to you how that's going to open some doors for us. Should we be on the alert already for things we can do, that we will be able to do that we can't do now for folks on Medicare? I
think that's a great question and certainly something I'm excited about. So currently, insulin costs are capped for everyone with Medicare at $35 a month out of pocket, and that's regardless of which phase they're in. So whether they're in initial phase or the donut hole or coverage gap or the catastrophic phase, the insulin costs are going to be capped or are capped starting this year for everyone. And then my understanding is that out-of-pocket costs for medications are going to be capped at $2,000 starting in 2025, is I believe the year I saw that happening, which is mind-blowing to me, given the cost of some of these medications and the fact that we're often recommending them, the people with these comorbid conditions and that have CKD or have heart failure and are indicated for SGLT2s or GLP-1s or for Narinone that we talked about today. I think it certainly is going to, if that is true, I always have a hard time believing that until it happens, until I see it at the pharmacy for the patient. But if that's true, I certainly think that's going to open the doors for us to follow the evidence and follow the guidelines for some of these high cost options.
Pardon my ignorance on the topic, but I think I'm underutilizing the pharmacotherapy clinics. And I wonder if you could tell a little bit more about how we can take advantage of those.
Yeah, great question. I will try to do my best. If somebody in the room or online is one of the many pharmacists that work in the pharmacotherapy clinics, they might correct me. But our pharmacotherapy clinics was kind of born out of our anti-coag clinics, and they can support us with treatment of Hep C. That is really where they started. They also are now supporting us with the treatment of osteoporosis when we're using kind of our more expensive medications such as Prolia or some of our anabolic agents. And then they help the specialty clinics with things like rheumatoid arthritis, I believe, and then HIV treatment and PrEP as well. And with a referral to the pharmacotherapy clinic, then those pharmacists are kind of well trained at identifying both right drug clinically and in this space of really high cost drugs, kind of insurance coverage or avenues to get the right drug for the patient. And then in many cases, because a lot of these medications require administration in clinic, such as Prolia for osteoporosis or such as cabotegravir for PrEP, or some of our other options require more monitoring and ensuring adherence, then they support all that, similar to how they have been doing for years with anticoagulant in terms of supporting monitoring and treat follow-up and adjustments as needed.
Great, thank you, Dr. Fry. Given the benefit of time, I may ask you one more question, perhaps a bit similar. You acknowledge the need for prior authorizations probably for several of these medications, which is increasingly back in the medical home for our patients as well. Any particular words of wisdom for the physicians or the teams as we're approaching prior authorizations to streamline the process?
Ooh, that's the $1 million question these days with the Providence Medical Group, I know. I think my best pieces of advice would be using our resources in Epic. Many insurance companies are now what I call talking to Epic and allowing a real-time benefit check at the time of prescribing in order to identify not only is a drug covered, but is covered actually affordable for the patient. So many times when I'm talking about a GLP-1 agonist or an SGLT2, even if it's covered, that might still mean a big cost share to the patient, which might not mean it's affordable. So I think those resources in Epic to identify, is it covered, is it affordable, and now should also show you if a PA is required, which can, I think from a provider's standpoint, can help with that conversation with the patient, letting them know that PA is going to be required, letting them know that's not going to be an immediate, like send to the pharmacy pickup later today, and can set up the rest of the support staff to complete that PA. I wish there was more direct advice to give you, but as we all know, it really is so payer dependent that there's not a one size fits all approach with these high cost drugs when a PA is required.
Great. Well, thank you so much for teaching us today, Dr. Fry, correcting some of our dogma with regard to prior prescribing and learning new cutting edge topics. So we so appreciate your support of our education. Thank you.